Greetings to one and all. Welcome to another WebSNAY with Delex. Hello to our invited speakers, moderator, to our program director, and most especially to you, our wonderful participants. Thank you, and we appreciate you for taking time from your busy schedule to be with us this afternoon, because I know some of you are on duty. Please do stay until the end, because we guarantee you that this afternoon is going to be a knowledge mining session. The last month's webinar on burns was graced with so much questions and positive feedbacks from the audience. We encourage all of you to have the same active participation for today's exciting session on SICU procedures. For today's webinar, our speakers will give us insights on the pearls and pitfalls in the placement of invasive vascular lines, as well as the assessment tools in sedation and analgesia in the ICU with some COVID-19 considerations. Again, the Delex Pharma and the Perioperative Care Forum team would like to salute you, our dear frontliners, for your dedication in fighting this pandemic. We promise to continuously provide you with updated and informative webinar topics. Thank you, and may our Almighty God guide you in your daily battle against this COVID-19. Back to you, Brad Pitt.
Thank you very much, Kay, and I hope we'll see you too live on cam. Beautifully brilliant people behind the ICU forum. Ladies and gentlemen, let's go now directly to the afternoon's event. Our moderator today, we are so blessed and we are so honored to have you with us. Currently, she's the chairman of the Department of Anesthesiology, Chongwa Hospital, Cebu. She's a member of Board of Directors, Philippine Society of Anesthesiologists, 2021. She's a regional director for Visayas, Philippine Society of Anesthesiologists, and she's a past president for PSA Cebu Central Visayas chapter. We are so honored and blessed to have you with us. So welcome this afternoon, Dr. Jennifer Francis Rosello.
Hello. Thank you for that kind introduction, Broad Pitt. Is that how they call you, Sir Hill?
It's anything just like it's simple as that, Doc. Welcome. Good to have you with us.
We like that celebrity name, Brad Pitt. Okay. Okay, so good afternoon. Hello, Philippines. I am so pleased to be the chosen moderator for our Perioperative Care Forum. Thank you, Delex Pharma, for the invitation. The topics that we will be discussing today, we are seeing a lot of lately. I know that we are not yet out of the woods in combating the crisis of COVID-19, and yet we are here. There are 1.9 thousand participants joining us this afternoon. Definitely, this is going to be a learning and worthwhile time that they will be spending with us. So, I've noticed that the topics we've chosen, SICU procedures, there's nothing that is decahon in our management of these cases, and choosing wisely is important. So we are very much interested to take a listen to our expert speakers for this afternoon. We will be starting off, with our first topic. Our guest speaker took his residency training in general surgery as the chief resident at that from Quirino Memorial Medical Center. He had his fellowship in thoracic and cardiovascular surgery, also as a chief fellow from the Philippine Heart Center. Currently, he is an active consultant at the St. Luke's Medical Center, Quezon City and Taguig City, also at the Medical City and Philippine Heart Center. He is a member of the International Society for Minimally Invasive Cardiac Surgery, a fellow at the Philippine Association of Thoracic and Cardiovascular Surgery, diplomate of the Philippine Board of Thoracic and Cardiovascular Surgery, diplomate as well of the Philippine Board of Surgery. Right now, he is the current training officer, post-residency vascular surgery training program at the Quirino Memorial Medical Center. Also, he stands as the head in the section of cardiovascular surgery at the Dr. H.B. Calleja Heart and Vascular Institute and St. Luke's Medical Center, Quezon City. So here with us to discuss on central venous catheter insertion and arterial line placement, let's all welcome Dr. Ramiro Thaddeus P. Pablo.
Thank you, Dr. Celio, for that kind introduction. Oh, okay, so we'll begin now. Sorry. Okay, again, thank you for the introduction, and thank you for inviting me to speak on this topic. So today I'll be discussing about the central venous catheter insertion and arterial line placement. So I have no disclosures. I do not promote any brand of catheter. No, I am connected with any company. So our goals today is to discuss the indications and techniques, the complications, the different types of catheters, also to iterate the importance of ultrasound guidance in these procedures. And this will touch up on the routine care indications for removal of the catheters. So central venous catheters, more commonly known as central lines or CVP lines, are indwelling catheters that we insert in large veins, and that the terminal tip is at the right atrium or superior vena cava. So the indications for central line insertion are: number one, hemodynamic monitoring. Here the usual what we usually monitor is CVP, and sometimes for capable ICUs we use PA catheters or the Swan guns, right heart catheters. Also to administration of hyperosmolar agents like TPNs. We can use also this for fast correction of potassium correction. We use vasopressors. Not commonly, we use this for transvenous cardiac pacing. More commonly, we have seen in most hospitals that we use especially the IJ, the internal jugular vein, as access for hemodialysis and plasmapheresis. At times, for lack of peripheral access and patients who have no peripheral access and need repeated blood extractions, we use the central venous catheters as access. So there are actually no absolute contraindications. What we have are relative contraindications. These are what this means are these are the factors, patient factors that we must be careful, must be wary about: coagulopathies, anatomic abnormalities, thrombus, stenosis. If there's localized infection or over the site of insertions like burns, wounds, and well, not commonly, but we have to be careful in patients who have recent pacemaker insertions, as we might dislodge the pacemaker which was recently inserted. So in patients with severe coagulopathy, it is, as I said, it's not an absolute contraindication, but we have to be wary. In patients with platelets of less than 50,000, patients who have an INR of 1.5 or greater, or in patients who have a PTT of 45 seconds or greater, studies have shown that these are not really absolute contraindications, but these are the patients that we have to be careful with. We have to weigh the risks versus the benefits. Although there is a risk of bleeding in these patients, uncontrolled bleeding, but the benefit or the need that with the central line insertion, if it's greater, then we should proceed, but only very carefully. We have to be careful in patients who have very low platelet counts. Studies have shown that there is really no need for routine corrections in patients who have very low platelet counts. But some studies have shown that if you have about 20,000, preoperative correction may be beneficial. So another relative contraindications is anatomic abnormalities. Although these are not really common in subclavian and femoral sites, however, in internal jugular veins, as you can see, the textbook anatomy is only about 50%, where the internal jugular vein lies over and lateral the carotid artery. So this is the to point out that we need or we encourage highly that you use an ultrasound when inserting IJ catheters or central line catheters, as this will help us see the adjacent structures and guide us so that we don't puncture arterial the arteries. So also thrombus and stenosis. If we use the ultrasound, we can identify this preoperatively, and then we can look for other sites that are better. So these are the three the usual access options that we use: the internal jugular, the subclavian, and the femoral artery. Femoral vein. So these each of these has their own advantages and disadvantages. The internal jugular being more accessible, easier to control the bleeding. Pneumothorax is uncommon, especially if you use ultrasound guidance. However, especially with blind insertions, carotid artery injury is possible. It is uncomfortable for patients, and the maintenance of dressing for the patients is a bit more difficult for the patients. In subclavian artery, it's more comfortable for patients with the location. The landmarks are clearer. The subclavian vein is less collapsible, and it actually has the lowest infection rates among the three sites. However, this has also the risk of the highest risk for pneumothorax. It is the subclavian artery is difficult to compress if you accidentally puncture it. And this is generally, we don't use the subclavian vein for dialysis, as this predisposes the patients for central vein stenosis. For the femoral artery, well, it is a bit, relatively easy because it is accessible, especially with ultrasound guidance. There's no risk for pneumothorax. However, the femoral vein has the highest rate of infection. And DVT is not uncommon, or deep vein thrombosis. Just to show you the studies that shown the rates of complications, as you can see, pneumothorax is highest in the subclavian vein, and arterial puncture highest at the femoral. Again here, the infection rate and the thrombus rate is highest at the femoral vein. So actually femoral vein among the three is the last option. So what are the different types of catheters? There are a lot of catheters in the market, but these are just a representative of what we use. We have the single lumen. These are very, very small catheters, just French 5 to 6. This is typically used for CVP monitoring. The advantage of this catheter is you can use it to insert a central line through the external jugular vein. However, because of the small caliber, just French 5 or French 6, it's not optimal for resuscitation, especially in patients who are hypovolemic. Other catheters they use are the double or triple lumen. These have diameters of about, these have larger diameters of French 7. This is what we usually use for central line. These have multi-ports, so you can use the multi-ports for multiple medications and also for monitoring. You can use the other ports for medications, and you can connect the other port to a transducer to measure CVP. It has multi-access. So we also have multi-access catheters. These are larger catheters, which is advantageous or better for a hemorrhagic shock resuscitation line because of its big caliber. It is easier to give blood, and can give boluses, and can give fluids faster. However, this typical type of catheter is much harder to insert. We also use the percutaneous introducer sheet. It has a diameter of French 5 to 8.5. We typically use this as an introducer for the Swan-Ganz catheter. However, these are only single lumen, and because of its short length, has limited access points, just the femoral and the subclavian. So lastly, we have the large diameter hemodialysis catheters. They are typically double or triple lumen. However, we do not use this typically as an IV access, because we have to preserve this so that hemodialysis schedules won't be interrupted. So important in central line insertion is doing an informed consent, explaining to the patient and their relatives the risk versus benefit. Some would say that this is just a simple procedure, but in reality, although it might look simple, the complications are real, and the complications are varied. So we have to explain thoroughly to the patient and the relatives the possible complications. Again, to reiterate, it is the importance of ultrasound guidance to limit your morbidity. It has been shown that with ultrasound guidance, the complication rates like arterial puncture and pneumothoraxes have decreased from 9% to about less than 3%. Okay. So also make sure that we do this in an aseptic environment. As a surgeon, I prefer to do it at the OR, but we understand that we cannot, there are patients that we cannot transfer from the ICU. So we can do it in the ICU. However, we should bring full drapes, all of the instruments, and have a controlled environment in the ICU. So to decrease the incidence of errors, make a checklist. So the American Association of Anesthesiologists had come up with their own checklist. I think for each of your own institution, you can come up with your own checklist so that we can minimize complications and errors. So work with an assistant to help you. This will make your insertion faster and easier. Also do post-insertion chest X-ray. This is not only to document the placement of the catheter, but also to document a pneumothorax or hemothorax. So this is just an example of the checklist that you can do. Everybody I know is familiar with this. Just a review of the anatomy. You see the jugular vein and the subclavian vein. They both drain into the IVC. The femoral vein is located in the femoral triangle with the nerve and the artery, all adjacent to each other. And here is the anatomical landmarks, external landmarks. For internal jugular veins, which we'll be focusing on today, we use the Sedilot's triangle. It is the triangle created by the sternal head, the clavicular head of the sternocleidomastoid muscle, and the clavicle. Inside there is the jugular vein. But as our previous slides have shown, ultrasound guidance will help you localize because the anatomy is not as constant as we would think, as we would want. For subclavian punctures, we usually puncture in the below the clavicle, below the medial 1/3 of the clavicle, and direct it towards the manubrium or the sternal notch. So in ultrasound guided insertion, you can use either an out of plane or an in plane approach. Personally, and I would recommend that you use an out of plane because the out of plane shows not only the vein, that your target vein, but also the adjacent structures like the artery. So you can avoid puncturing it. So just a short video on IJ catheter insertion. I'd like to take the residents from QMMC for doing this. So you need to prepare your materials prior to the procedure. You have to prepare it well, make sure it's complete, make sure it's accessible. And then you can prep the CDC recommends a chlorhexidine-based prep, but you can use whatever it is that you have in your institution. What is your protocol? So make sure you have an assistant. Again, full draping is very important, so we can avoid catheter-related bloodstream infections. As you can see here, we used a full drape. Then preoperatively, you scan. You can see the arterial jugular vein is the compressible one. And with ultrasound guidance, you can actually see the point when we puncture the vein. As you can see here, and you can see there, you punctured it, the needle is inside the jugular vein, and then you hold your needle and remove the syringe. You see it's there's no pulsatile flow. You make sure that when you insert the guide wire, it's smooth. There are no there's no resistance. And I would recommend that prior to insertion, you check the location of your guide wire. Make sure that it is in the jugular vein. You can see here. So that before dilating or inserting your catheter, you'll know that then you're in the right place. Now enlarge your puncture site so you can put in your dilator. Okay, so different brands come with different types of dilators and different number of dilators. The larger you have, the more the larger the catheter, the more dilators you have. Then preoperatively, you should have already approximated the level. There's a measure actually printed at the catheter. Then make sure you remove the guide wire. Don't forget. This is a common mistake. You might forget your guide wire. Now make sure that there is no resistance. Flush your aspirate and flush your all your ports. You can use a prepared heparinized solution, or you can make your own. Like 0.1 cc of heparin, mix it with 100 cc of plain NSS or water for injection. And then make sure that you anchor your catheters. This is the adjustable suture wing. Make sure that you anchor it well so it will not be pulled out. So it can be a great help if you know how to do a post-insertion ultrasound. Just to show you, this is the chest ultrasound. As you can see, that is the lung actually sliding the pleura. So this indicates that there is no pneumothorax. If that white line there does not move, it means probably you have a pneumothorax. And do a chest X-ray and refer to a surgeon. So there are immediate and delayed complications. These are the immediate complications. In cardiac, we usually encounter this, the arrhythmia, when your guide wire is too deep or you insert your catheter too deep. Usually this just resolves with pulling out the catheter or the guide wire. But in cases that a patient becomes unstable and arrhythmia becomes persistent, you have to be prepared to do an ACLS. Although rarely it happens, it has not yet happened to me. Perforation is very rare because the guide wires and the catheters that we use right now are very soft, and I don't think they can perforate the atrial or ventricle. However, this may happen if you have to have this index of suspicion if you have sudden hypotension and you have the Beck's triad, which means a distended neck veins, muffled heart sounds, and hypotension. This is present in about 25% of patients. So in these cases, do an immediate 2D echo or a cardiac ultrasound. If there is evidence of tamponade, refer immediately to a surgeon or interventional cardiologist so we can do percutaneous pericardiocentesis. Worst cases, we have to do surgery to close the wound. So more commonly, the vascular complications, we have an arterial puncture, which happens in about 4 to 9% of the cases. What you do this, if you have not yet dilated your vessel, you just pull out the needle and pull out the wire and do manual compression for about 5 to 10 minutes, and then you can insert again. But in the instance that you dilate or cannulate the artery, we recommend that you do not remove the catheter. This you will note this when after you inserted your catheter, there is a pulsation, there's pulsatile flow, there's bright red flow in your catheters. So do not remove the catheter. Refer to a vascular surgeon. So this can be managed surgically. So also, if there are lacerations, there are hematoma, you need to refer to a vascular surgeon so we can assess if this is we can treat this conservatively or we need to do surgery. So pneumothorax and hemothorax, with the advent of ultrasound guidance, has become less and less. It has become rare, but we need to document this. So as we discussed earlier, do a post-insertion ultrasound, chest ultrasound, do a chest X-ray. If there is a finding of pneumothorax or hemothorax, you refer immediately to a thoracic surgeon, because majority actually of these cases will resolve with just a chest tube placement. So rarely tracheal or injury or chylothorax. So abnormal catheter placement, if you have abnormal anatomy, especially in patients, we have persistent left superior vena cava. This is only present in less than 1% of the population, but this can actually cause systemic emboli and arrhythmias. So in these cases, you remove and immediately reinsert. We have a resident who had the luck of inserting this into the persistent left SVC twice in the same day. So this can happen. In these cases, you have to remove this immediately and reinsert. So again, to reiterate, complications can happen. So preoperative explanation and informed consent is very important to minimize us getting into trouble. Among the delayed infections, delayed complications is infection and catheter dysfunction. So in catheter dysfunction, we have to immediately replace the catheter. We can do this over the wire, so we don't have to get a new insert to a new site. Infection. The CDC has determined central line associated bloodstream infection, or CLABSI, as infection in catheters placed more than 48 hours. It is confirmed by laboratory, meaning there is already a culture and you have no other identifiable source. So this can happen because of contamination during insertion by the surgeon or the interventionalist, catheter care by the healthcare workers or the patient, or patient factors such as malnutrition and or patient hygiene. So just to summarize, this is the recommendation. To summarize, when you establish a diagnosis of CLABSI, you need to remove the catheter, either replace it over the wire or find another site. You need to culture the tip so that you can institute pathogen-based antimicrobial therapy. So next, we will go into arterial line placement. In about a third of ICU patients in the US, they undergo A-line insertion. In our specialty, this is very routine for cardiac surgery because we need to monitor accurately the blood pressure intraoperatively and postoperatively for all cardiac patients. It can measure the BP more accurate than the BP cuff, especially in hypotensive patients. And it has the advantage of real-time response therapy. You can actually see in real time if you give a medication or a vasopressor now, in a few minutes, you can see its effect. You don't have to wait for the BP cuff to get its reading. This is a second per second reading. So it has a relative low complication rate of about 1 to 5%. So uh, the radial and the femoral artery are the common sites of insertion. However, we use the radial artery as much as we can because the hand has a double blood supply, the radial and the ulnar. So even if you have complications with the radial artery, you will the chances of having an ischemic complications are very, very low because you have another blood supply, which is the ulnar artery. So the indications again, continuous beat-to-beat monitoring. If you have frequent blood sampling for labs, like especially for ABGs, you can use the arterial line for extraction. And for femoral artery insertions, we can use this as an access for the intra-aortic balloon pump. The catheter, the arterial catheter, is usually, the duration is just usually stays for about 5 days. After this, you have to remove or replace it. This is because after 5 days, the line becomes damped. The readings will not be accurate. And usually after 5 days, the patient is stable enough to warrant removal of the warrant monitoring of arterial line via intravascular monitoring. So contraindications, if your patient has arterial vascular insufficiencies, if you have peripheral arterial diseases, you have small vessels, and you have anatomic variance. Example, if you have if you have no ulnar artery, do not insert. Avoid inserting it to the radial artery. Find a bigger artery. So complications that could possibly arise are thrombosis. This may lead to ischemia, especially if you use the brachial artery. If you have thrombosis, this might lead to ischemia. Peripheral nerve damage, you can puncture or injure the adjacent nerve, but this is lessened with the use of ultrasound. And also pseudoaneurysm, this can happen after removal of the catheters, and you have inadequate pressure after removal. This can cause pseudoaneurysm. So these are just samples of the catheters that can be used. The catheter that we use right now is the one with this built-in guide wire already, so it is easier to insert. We can also use the cordy sheet that we use in IJ and femoral vein insertions. Here, I will just show you a video of how we do it. So you scan preoperatively prior to puncture. As you can see, you can identify there the radial artery, which is pulsating. You can identify the depth. You can use color flow for hypotensive patients. It's not pulsating. So to verify if that is the artery. With the ultrasound, you can also measure it. So you know if you will not have problems with the insertion. So after prepping the whole hand and the arm, we do the insertion via ultrasound guided. So you do the puncture. We can see the point in time where you puncture the artery. And to confirm that, you can see blood through the receptacle of the catheter, as we'll see here. So we have confirmed already that we punctured it. You can see there is blood, backflow, bright red blood. You push down the guide wire, make sure that there is no resistance, and then push in your catheter. As you can see, when you remove the guide wire, there is bright red blood. Then we connect it to a transducer. Also, you can see here to confirm that you're in the artery. You have pulsatile flow, and it is bright red. Final confirmation is after you connect it to your transducer, look at in the monitor, there is the normal arterial waveform. You have the upstroke, the downstroke, and the necrotic notch. And this is where you connect it, connect it to a pressure transducer with an automatic flushing system. Thank you. That is the end of my lecture. If you have, we'll have next the question and answer. We'll have the poll questions. Can you please post the poll questions? Okay. So poll question number 1 is, which has the highest rate on infection in central line catheterization? Is it subclavian vein, femoral vein, internal jugular vein, or the external jugular vein? Please click your answers and please submit. Press submit. Okay, can you now let's see the answers of everybody. Okay, that's majority of you answered femoral vein. Yes, this is correct. This has been established by studies. Also, because of its location, it has the highest rate of infection. Can we have the next poll question? So the next question is, this is the first choice in arterial line catheterization. Is it the carotid artery, ulnar artery, radial artery, or the femoral artery? Okay, so please click on your answers and press submit. Okay, can we see the answers? Yes, that is correct. We insert it to the radial artery because the hand has a double blood supply, the ulnar and radial artery. We do not, we avoid the carotid artery because this can cause stroke. So carotid artery is not an option actually in arterial line insertion. Okay, so that ends my lecture. I'll be happy to answer your questions. We'll have an question and answer time after the lecture of the second speaker. I'll be happy to answer your questions. Thank you very much.
Okay, ladies and gentlemen, that is Dr. Thaddeus Pablo. We are now ready for the icebreaker. Okay, icebreaker, 4 picks, 1 word. I'm sure you know how to play this game. 4 picks, 1 word. Make sure you get to guess among the pictures that we're going to share to you. Guess the right answer. Type your answer in the chat box. The first 3 right answers will win 2 boxes of Easy Vit multivitamins worth 710 pesos. We will type the name of the winners in the chat box. Are you ready? Okay, raise your hands, wave your hands, smile. I would rather suggest you smile. I can see you smiling. Your hearts are smiling. Okay, here we go. 4 picks, 1 word. Okay, let's turn in the IT guys. Will show us the 4 pictures. 4 pictures. Next slide, please. Here we go. Okay, the first picture we have right on screen. How would you figure this out? 4 picks only for 1 word. Next picture, please. Second picture. How do you figure this out, ladies and gentlemen? And we'll show you the third picture, please. There you go. You got 1 more. I'm sure you've guessed it right already. Last picture, IT, our IT crew, and that's it. As they suggest, 4 picks, 1 word. Did you guess it right? I'm sure you did. All right, guys, are you ready for the word for this 4 pick 1 word icebreaker? And the right word is, here we go, flash the word. That's the right answer, sedation. Ladies and gentlemen, congratulations for the winners. Multivitamins Easy Vit. It will be flashed on the chat box, all right? So please do pay attention. So stand by for more. We're still halfway through the lectures. We'll be presenting some AVPs for you. Care LGL and Delax Pharma introduce NeutraClear, a completely transparent neutral displacement connector that prevents catheter-related bloodstream infections. Its exclusive design guarantees that best practices are followed and ensures patient safety. NeutraClear's smooth, flat septum makes it easy to disinfect. The guiding seal ring protects needleless connector's integrity. Its 2.8 centimeter size and 1 gram weight reinforces care comfort in neonatology and pediatrics. The neutral displacement design prevents blood reflux in the catheter. Thus reduces the risk of occlusions and infections in the catheter. Its completely transparent needleless connector ensures best hygiene practices and is recommended by experts for effective flushing. NeutraClear, the closed system which guarantees neutral displacement and complete transparency to prevent catheter-related bloodstream infections.
And now we are on to our next topic. We have our invited speaker for this afternoon, who had his residency training in anesthesiology at the St. Luke's Medical Center, Quezon City. He further trained in advanced clinical anesthesia, acute pain medicine, and intensive care medicine at the Royal Perth Hospital, Australia. He is a board-certified consultant both in anesthesiology and pain medicine. For his current affiliations, he is an active consultant at the Department of Anesthesiology, St. Luke's Medical Center, Quezon City, Fellow of the Philippine Society of Critical Care Medicine, founding member, Enhanced Recovery After Surgery, Society of the Philippines. He is an instructor of basic assessment and support in intensive care course. He is the head of Systems Investigation and Analysis Committee at the Department of Anesthesiology, St. Luke's Medical Center, Quezon City. Also a head in the Cardiovascular Telemetry Unit and Pulmonary Care Unit of St. Luke's Medical Center, QC, and the section head as well of the Intensive Care Medicine Department of Anesthesiology, also from the same institution, St. Luke's Medical Center, Quezon City. We go a long way back. Dr. Noel Belay, let's all give him a warm round of applause and welcome. Hello, Dr. Belay.
Good afternoon, colleagues. Sedation and analgesia in the ICU is one of the important aspects of ICU care and are primarily indicated to prevent self-harm and ensure patient comfort. This afternoon, I hope to discuss the goals in ICU sedation and analgesia, whether it's patient comfort or a deep level of sedation. I will talk about the principle of analgosedation and clarify some misconceptions about it. Next will be about sedation assessment tools and the targets which we want to achieve. I will also talk about the drug choices in ICU sedation and analgesia and some important non-pharmacologic techniques to help alleviate discomfort. And lastly, I will talk about some COVID-19 considerations regarding sedation and analgesia in the ICU. The first thing you have to ask yourself is whether your patient needs to be sedated. And there are only two general goals for ICU sedation: to provide pain relief and patient comfort, and the second is to prevent self-harm, needing a deep level of sedation, which may even need paralysis. If your goal is patient comfort, this means someone who is calm and communicating. They may be asleep, but they can easily be awakened. For the majority of post-operative patients, patient comfort will be your goal, and your options include non-pharmacologic techniques, and I will discuss that later. You can use non-opioids, maybe some opioids, dexmedetomidine, or propofol. If your goal is to have a deeply sedated patient, to facilitate ventilator synchrony, or to prevent increases in ICP, like in cases of traumatic brain injury, or as part of targeted temperature management in post-arrest patients, you have the same drug choices, of course at a higher dose, and the only difference is that with a deep level of sedation, you have an option of giving neuromuscular blocking agents. The first step is to assess for the presence of pain and control it if there is, and if there's none, please don't sedate with opioids. Analgosedation is based on the principle that it is better to treat disease, which is pain, than to mask it with sedatives. It is the practice of treating the pain with analgesics like opioids before actively sedating the patient, because in this way, once pain is controlled, the patient can then be put on minimal or even no sedation, avoiding oversedation. Analgosedation can be defined as analgesia-first sedation. Analgesia-based sedation, on the other hand, is where an analgesic, usually an opioid, is used instead of a sedative to reach the sedative goal. Imagine a patient who is agitated but without any pain. If such a patient were treated with opioids, they would require higher doses of opioids to take advantage of the sedative effect. This is because either morphine or fentanyl is a potent analgesic but a weak sedative. In analgesia-based sedation, you're essentially using high-dose opioids as a broad-spectrum quiet-down drug to treat anxiety or agitation. Bear in mind that the side effects of opioids are dose-dependent. The more opioids you give, the more side effects you get. So I don't recommend this practice, particularly as a primary technique to sedate. Provision of analgesia is very important because ICU patients experience pain at greater rates than other hospitalized patients. Here you will see that up to 80% of ICU patients experience pain, and that the most painful procedures are actually the common ones like tracheal suctioning, drain removal, and patient turning. This paper shows the effects of traumatic experiences in the ICU like pain, fear, anxiety, inability to sleep, and nightmares. You will see here that up to 75% of ICU patients and family members develop anxiety, depression, and PTSD from these traumatic experiences even after 4 years. Of interest is this cohort of 230 patients, which concluded that the incidence and intensity of pain is the same in surgical and trauma ICUs and medical ICUs. This was a survey on the pharmacologic knowledge of the physician house staff and intensive care nurses regarding the analgesic and anxiolytic effects of narcotics, benzodiazepines, and neuromuscular blockers. The results showed a commonly held misconception that muscular paralysis is a calm and painless state, as well as diazepam's pain relief. Opioids are the most frequently used drugs for pain in the ICU. In fact, up to 90% of ICU patients receive opioids. Remember that they don't have amnestic effects, and so be careful about awareness and recall. They also have several adverse effects like respiratory depression, nausea and vomiting, ill use, tolerance, withdrawal, and hyperalgesia. Also, opioids in itself can cause delirium, so bear in mind this side effect as well. I would like to emphasize that because of the wide variation in opioid requirements between patients, the effective dose of an opioid is determined by each patient's response, not by the dose range. A popular opioid in the ICU is morphine. It has active metabolites that can accumulate, particularly in those with renal dysfunction, as well as in liver disease. Another opioid is meperidine. Although some would use it for renal or biliary colic, it actually has no role in pain management in the ICU and is not recommended because of its metabolites that can cause CNS excitation, seizures, and even more agitation. Remifentanil is a potent, ultra-short duration opioid that does not accumulate even in hepatic and renal failure. It has the same side effects like the other opioids like hypotension, bradycardia, and chest wall rigidity. You can also develop tolerance from it after some time. Another important concern as well would be the development of hyperalgesia, which might require more rescue doses of opioids after you stop it. The most popular in the ICU is fentanyl because of its rapid onset. Nice thing about it is that it is essentially a clean drug. If your patient is awake, the best way to administer your opioids in the ICU is by a PCA. With a PCA, the patient gets a psychological benefit of having autonomy and control over his or her pain. It is practically safe because of the inherent safety principle. You only get what you need. This slide shows the standard prescription of the PCA. Note here that the patient should be comfortable before starting the PCA which means you may need to give titrated boluses to control the pain before starting the PCA. Also note that we don't give a continuous rate unless you have a chronic pain patient and you already know his or her opioid requirement. This is the WHO pain ladder showing how to start your analgesics. And as you can see, we should start with non-opioids like paracetamol and adjuvants, then progress to strong opioids and interventional techniques. These are some adjunct non-opioids which will help in reducing opioid and sedative use. Following the WHO pain ladder, start with these non-opioids first before giving opioids, so that if we are able to control pain with these non-opioids, then we are able to avoid opioids and its side effects. Regional anesthesia can also be used in ICU patients. They provide significant pain relief and will reduce or even avoid opioid and sedative use. Ketamine is an NMDA antagonist which provides intense analgesia even at subanesthetic doses, which may prove to decrease opioid use. It may, however, precipitate hallucinations that can be attenuated by simultaneous benzodiazepines, but usually these hallucinations are mild and easily controlled by decreasing the infusion rate. At low infusion rates, psychomimetic side effects are not really a major problem. Top tip number 2 is target an awake, communicating patient shortly after intubation. Deep sedation is understandably used following intubation in the ER or operating room in order to facilitate safe transfer to the ICU, but more often than not, deep sedation is continued on admission to ICU. This multi-center prospective longitudinal cohort study from 25 Australian and New Zealand ICUs involving 255 patients identified that deeply sedated patients within 4 hours of commencing ventilation and after 48 hours had longer time to extubation and higher hospital death and 180-day mortality. This confirms that more sedation is not necessarily better. This RCT of 137 ICU patients requiring mechanical ventilation, which looked at the subsequent patient mental health of lightly sedated versus deeply sedated patients, suggests that light sedation reduces ICU stay and duration of ventilation. Top tip number 3 is to use appropriate non-pharmacologic and pharmacologic interventions for different symptoms, ideally with patient input. The ideal situation is an awake patient who can communicate his or her symptoms so that the caring team can provide the appropriate medication to treat the specific symptom. While pharmacologic agents are often necessary to manage pain and anxiety, their use may be reduced and effectiveness enhanced by multifaceted non-pharmacologic interventions. When we've decided that our patient needs sedation, the next question is, what is the ideal sedative drug? The answer is none. No single medication can address pain, anxiety, agitation, and sleeplessness all at the same time. Therefore, several medications at low doses in combination may be required to obtain different benefits and to minimize its side effects. For others, the ideal sedative is only what the patient needs, and for some, it may be nothing at all. Again, if a patient is in pain, give a pain reliever and not a sedative. If the patient is agitated but not in pain, give a sedative and avoid opioids. Although lacking a strong evidence base, antipsychotics like your haloperidol or your atypical antipsychotics may be used for patients who experience significant distress secondary to delirium, such as hallucination and/or delusion-associated fearfulness, or who are delirious and have agitation that may be harmful to others or themselves. Antipsychotics, however, should be stopped immediately following the resolution of the patient's distressful symptoms. Known adverse effects are QT prolongation, hypotension, and neuroleptic malignant syndrome. In this randomized double-blind placebo-controlled trial by the Mind USA investigators involving 566 ICU patients with delirium, haloperidol or ziprasidone, as compared with placebo, did not significantly alter the duration of hypoactive or hyperactive delirium. It should be noted, however, that 89% of those with delirium had the hypoactive type, which could be interpreted as a non-improvement. Melatonin is a hormone that plays a central role in sleep-wake regulation and decreases the breakdown of tryptophan and serotonin through negative feedback. Due to the lack of high-quality evidence, the PADIS guidelines made no recommendation regarding the use of melatonin to improve sleep in ICU patients. It may, however, be a treatment option on the basis of its physiologic mechanism and also because it has an impressive track record of safety, being available over the counter. Having in mind the cost of ICU delirium versus the cost of melatonin, even if it's marginally effective, it becomes a cost-effective option to improve sleep and reduce delirium. This double-blind RCT in 2015, comparing melatonin 6 mg versus placebo, showed that melatonin decreased the need for sedation and also improved neurologic indicators with reduced costs for neuroactive drugs. It also hastened weaning from mechanical ventilation. This double-blind randomized placebo-controlled study, published 4 months ago, involving 203 adult ICU patients given analgesics and/or sedatives, showed that melatonin was associated with better sleep quality. Dexmedetomidine, a selective alpha-2 receptor agonist with anxiolytic, sedative, and analgesic properties, is a popular choice for sedation because it has minimal respiratory depression. With dexmedetomidine, patients can be aroused without discontinuing the drug infusion, and when awake, patients are able to communicate and follow commands. This has been called cooperative sedation and is similar to temporary awakening from sleep. In fact, the EEG changes in this type of sedation are similar to the EEG changes in natural sleep. It can be used as a sole sedative drug for light sedation, but is not suitable when deep sedation is required. It is associated with less delirium than other sedatives and may be the drug of choice for the treatment of delirium. In addition, it has no active metabolites, making it a popular choice for patients with hepatorenal dysfunction. Common side effects include hypotension and bradycardia, often with a loading dose. It has a role in weaning sedation, as well as during the transition period from mechanical ventilation to spontaneous breathing. In this open-label randomized trial comparing dexmedetomidine as the sole or primary sedative versus the usual sedatives like propofol, midazolam, or other sedatives, subgroup analysis showed lower mortality with dexmedetomidine in older patients. Propofol, as you know it, is a hypnotic with anticonvulsant and antiemetic properties, but no analgesic properties. It has no active metabolites. It is delivered in a fat emulsion that provides 1.1 kcal per ml, so consider this when adjusting nutritional requirements. Common side effects include hypotension, myocardial depression, and respiratory depression. It can also cause pancreatitis and the rare propofol infusion syndrome. It is recommended to avoid giving more than 4 milligrams per kilo per hour and to monitor your CK and triglycerides daily when given longer than 2 days. The latest 2018 PADIS guidelines suggest using either propofol or dexmedetomidine for sedation in critically ill, mechanically ventilated patients. This multi-center double-blind trial 2 months ago, involving 422 patients given light sedations, looking at the days alive without delirium or coma, ventilator-free days, and 90-day mortality, concluded that there's no difference in outcomes between those given dexmedetomidine and those given propofol. We've discussed about several drug therapies to provide patient comfort, but also important are the use of non-pharmacologic interventions for patient comfort, and this is top tip number 4. This quality improvement study on 116 ICU patients who were asked about the quality and quantity of sleep and the factors contributing to poor sleep reported that the quality of sleep of 59% of patients were poor or very poor compared to 24% at home. In addition, 76% of patients responded that they did not have a normal sleep-wake cycle, and the 5 most frequently cited reasons for this were noise, pain, light, loud talking, and intravenous catheters. These stressors generate discomfort, anxiety, and may promote delirium. These are some non-pharmacologic measures that are relatively low cost and safe and may reduce patient and family anxiety or stress. Minimize noise, ensure communication by using visual aids, word charts, and writing tools, orient the patient to place, day, and time frequently, reduce ambient lighting during nighttime, music therapy, comfortable positioning, and ensuring ventilator synchrony. Top tip number 5 is when deep sedation is needed, de-escalate ASAP. Some ICU patients require deep sedation to facilitate specific interventions such as management of ICP, prone positioning, and neuromuscular blockade. The need for deep sedation should be assessed frequently, at least 4 times daily, and once the indication for deep sedation has resolved, medications should immediately be reduced and stopped. This RCT of 137 ICU patients requiring mechanical ventilation, which looked at the subsequent patient mental health of lightly sedated versus deeply sedated patients, suggests that light sedation reduces ICU stay and duration of ventilation. This multi-center RCT, the ABC trial, involving 336 patients who underwent either daily sedation interruption plus a daily spontaneous breathing trial or a daily SBT alone, showed that patients in the daily sedation interruption plus SBT group had more ventilator-free days and were discharged earlier from ICU and hospital. It's interesting to note here that there was an increase in self-extubation rates in the daily sedation interruption plus SBT group, but no increase in the rates of reintubation. The graph on the right is a comparison of 1-year survival, showing that patients managed with the spontaneous awakening trial plus SBT strategy were 32% less likely to die than patients in the control group. This multi-center North American RCT sleep trial, involving 430 patients who underwent daily sedation interruption plus protocolized sedation or protocolized sedation alone, showed no difference in the duration of mechanical ventilation, ICU, and hospital stay. There was, however, higher mean doses of sedatives and higher self-assessed nursing workload with a daily sedation interruption group. The message here is that daily sedation interruption offers no additional benefits when you have a sedation protocol targeting light sedation. You're called by the nurse for an agitated patient. What will you do? Will you give an antipsychotic to the nurse? Will you give diazepam to the patient? Or take morphine for yourself? Or look at the patient? You're a good doctor and so you will assess the patient. Despite a systematic process, pain remains to be a major stressor in the ICU. In fact, chronic pain is increasingly being recognized as a sequel in survivors of critical illness that negatively affects quality of life. A possible cause explaining this problem is because pain is either inadequately treated or not properly detected. It is common to use hypertension and tachycardia as indicators for the presence of pain, but these papers show that hemodynamic measures like your blood pressure and heart rate are not suitable indicators as they can remain unchanged in the presence of pain. Clinical practice guidelines tell us that vital signs used alone are not suggested for pain assessment in adult ICU patients. This leads me to top tip number 6, which is to use assessment tools and set a sedation level target. This is the Richmond Agitation Sedation Scale. A target sedation score is set regularly, like twice daily, and the default is set to target a comfortable, oriented, alert, or easily rousable, cooperative patient, and this is a score of -2 to 0. If you're managing ICPs, seizures, severe ARDS requiring muscle paralysis and prone positioning, then you need a deeper level of -3 to -5. Patient self-report is best for pain assessment using the numerical rating scale on the left, and if unable to communicate, use the critical care pain observation tool on the right. Another is the behavioral pain scale, and both are valid and reliable. This should be done every 4 hours, and a rating scale of 4 or more and a CPAT of 3 or more predicts the presence of pain requiring intervention. This is the confusion assessment method for the ICU tool. It is recommended that you do the assessment once daily or more frequently if the patient's behavior changes. If 1 plus 2 and 3 or 4 present, then you have delirium. This cohort study testing the CAM ICU tool involving 96 patients showed that delirium is extremely common in mechanically ventilated patients. 8 of 10 patients have delirium. Of interest is that delirium is present in 4 of 10 alert or easily aroused patients who are usually assumed to be cognitively intact by ICU staff, and delirium persisted in 10.4% of patients at hospital discharge. The most common type of delirium, hypoactive or quiet delirium, is often not recognized because it is not overtly problematic compared to the hyperactive or agitated type, but may portend a worse prognosis than hyperactive delirium. This cohort of 275 mechanically ventilated patients showed that delirium was an independent predictor of higher 6-month mortality and longer hospital stay. Top tip number 7 is to use an intermittent or a PRN bolus of benzodiazepines for palliation, seizures, procedural amnesia, and alcohol withdrawal. Top tip number 8 is to identify opioid and benzodiazepine withdrawal because prolonged treatment with these drugs results in physiologic dependence, and rapid tapering or abrupt discontinuation can precipitate iatrogenic withdrawal syndrome, which may be associated with adverse outcomes including agitation, delirium, and prolonged mechanical ventilation. This study involving more than 1,100 pediatric ICU patients showed that iatrogenic withdrawal syndrome is common in those who receive greater than or equal to 5 days of opioids and sedatives. Top tip number 9 is to remove unnecessary catheters and drains to improve patient comfort, reduce agitation, and facilitate mobilization. Physical restraint use should be avoided or minimized as it causes patient injury, increased agitation, and psychological distress for patients and family members. This paper on 31 surgical ICU patients who had unplanned extubations noted that the use of restraints does not tend to prevent unplanned extubation. In fact, 87% of patients who self-extubated were restrained, and half of these patients were reintubated. They also estimated a $1,000 additional cost for every reintubation event. This study on more than 1,700 subjects intubated for mechanical ventilation reported that physically restrained patients were 5 times more likely to experience unplanned extubation. Top tip number 10 is do not increase sedation at night for the purpose of promoting sleep. The secondary analysis of the sleep trial involving 423 mechanically ventilated patients found that patients receive higher doses of opioids and benzodiazepines at night, and higher nighttime doses were associated with SVT failure and delayed extubation. This highlights the importance of minimizing sedation at night as well as during the day, and sedation should not be increased at night for the purpose of promoting sleep. Melatonin or non-benzodiazepines can be considered for sleep promotion in addition to non-pharmacologic measures. The ECASH concept, which means early comfort using analgesia, minimal sedatives, and maximal humane care, aims to establish optimal patient comfort with minimal sedation as the default presumption for ICU patients. Pain relief and light sedation will promote sleep, early mobilization, and improve communication of patients with staff and relatives, all of which may be expected to assist rehabilitation and avoid isolation, confusion, and possible long-term psychological complications of an ICU stay. The ECASH concept basically summarizes the integrated approach to ICU sedation. Some considerations during the present pandemic. COVID patients require higher doses of sedatives for long periods of time. Fatigue is already a common concern about the staff because of the high workload, not only because of the overwhelming number of patients requiring extra precautionary measures, but also because of the manpower shortages. Drug availability and cost are issues as well. Analgesia alternatives in COVID-19 include maximizing your non-opioids, PRN boluses first before deciding on an infusion, enteral opioids using continuous release preparations, the use of fentanyl patch, and COX-2 inhibitors when the risk is low. Light sedation alternatives include the use of clonidine, sub-anesthetic doses of ketamine, intermittent benzodiazepines, enteral diazepam, or the use of antipsychotics. Deep sedation alternatives include using ketamine at more than 0.4 to 1 milligram per kilo per hour, or the use of volatile gases either using anesthesia machines or anesthetic reflector devices. Guidelines and recent reviews based on the RCTs suggest that NMBAs should be avoided in ARDS unless there is moderate to severe ARDS, ventilator desynchrony despite deep sedation, prone ventilation, and high level of inspiratory efforts. As needed or intermittent boluses are preferred, over continuous infusion for up to 48 hours. When you have a limited supply of atracurium or cis-atracurium, you can use vecuronium or rocuronium in patients without organ dysfunction given as intermittent or PRN boluses. In summary, pain assessment is very important before starting any sedative or opioid, and this is the practice of analgesia first sedation. Remember to follow the WHO pain ladder and consider non-opioids first before the opioids. Target an awake, comfortable, and communicating patient, and so less sedation is better. Multimodality and multifaceted non-pharmacologic interventions reduce sedative use. And lastly, use assessment tools with appropriate sedation targets to improve outcomes. We have to individualize our approach in sedation because ICU patients have different requirements, comorbidities, organ dysfunctions, risk, severities, and at different stages of their disease. With a wide variation in ICU patients, the hard truth is that not all ICU patients can be saved, and so our principal goal in patient care is not to save lives, but to relieve pain and suffering. And with that, I'm happy to answer any questions that you may have.
All right, thank you. For the first question, what best describes analgo sedation? Letter A, analgesia-based sedation. Letter B, analgesia-first sedation. Letter C, use of opioids as a quiet-down drug. And letter D, opioids and sedatives used in combination always. So please type your answers. Can we have the answers, please? Okay, so the correct answer is analgesia first sedation. So we have to address the pain first if there is, and if there's none, please don't give opioids. Question number 2, please. So pain assessment tool that should be used in ICU patients who are unable to communicate. Letter A, Richmond Agitation Sedation Scale. Letter B, Critical Care Pain Observation Tool. Letter C, heart rate. And letter D, blood pressure. Please type in your answers. Can we have the answers, please? The correct answer is the Critical Care Pain Observation Tool. The Richmond Agitation Sedation Scale is for the sedation level, not for the pain score, or not for the pain level. Thank you.
So there you have it, ladies and gentlemen. And we are now getting ready for the live question and answer. To make it even more interesting, we would like to call back on screen live Dr. Thaddeus Pablo, Dr. Noel Belay, and our beautiful moderator, Dr. Jennifer Rosello. Doctors, it's all yours.
Hello. Welcome
Hello.
again, Dr. Belay and Dr. Pablo.
Hello, hello, ma'am.
Hello, hello.
Hi. Okay, so our Q&A box is already flooded with questions. Si Dr. Pablo already had the time to rest, so I will direct the first question to you.
Yes.
From what you have lectured to us, we see the practice patterns and maybe against the patient factors that that we see with regards to the choice of the central vein catheterization that will be needed. So I will have one question here to ask you now. On which cases do we choose CVP tip in the, should be it in the SVC or in the atrium? Because you have mentioned that there will be instances wherein you can have the tip at the SVC or in the right atrium. Is there any requirement for that? Which cases will have?
Actually, no. The ideal location is actually at the junction of the SVC and the atrium. But there's really no hard and fast rule. You can put it a little bit deeper into the atrium. Actually, for long-term catheters, for dialysis catheters, the permanent catheters, you actually put it more deeper into the atrium. It's just that it's bigger. It has less chance of being clogged or being sticking to the vessel. But if we go by ideal, the ideal is actually at the junction of the SVC and the IVC, which is it's really difficult to put it in the exact place. But either you can do it, you can put it there.
Okay, as long as you also do not elicit any arrhythmia.
Yes, yes.
Okay, all right.
Can I add to that, Dr. Roselio?
Go ahead.
Okay, so yes, I agree. The ideal location is just at the junction of the SVC and the RA. So what I do actually is the way I estimate the level is to get the patient's height and divide it by 10. Or if I'm using the chest X-ray, around 2 cm above the carina.
Okay, so that would be the height, your height in centimeters?
Yes, or divided by 10.
And
or
then
that would be the level of your catheter insertion. Or if you want to base it on the X-ray, around 2 cm above the carina. Or as a general rule, if you're inserting on the right, just don't go beyond 15 centimeters. And if you're inserting on the left, just don't go beyond 18 centimeters.
Oh, okay. So that's one lesson to be had this afternoon, no? For those who are inserting these kinds of lines for surgeons and anesthesiologists alike. Another question, Dr. Pablo. Thank you very much, Dr. Belay. Is it contraindicated to insert an IG cath in patients with AAA? So
no, actually, abdominal aortic aneurysm, no. Actually, we routinely do that before for patients who undergo AAA repair, whether catheter based or open. We do insert a central line. Our anesthesiologists actually do that for us for monitoring of the CVP. We usually use in our practice, we usually use a Swan-Ganz catheter.
Correct. Actually,
it is not contraindicated.
It is even beneficial.
Yes, yes.
Thank you. Sa'yo naman, Noel, ha? Okay. First question that we got for Dr. Belay. What is more advantageous, PCA or epidural continuous analgesia in the ICU setting?
Well, it depends on the type of, depends on the indication. If, for example, you have an operative patient, for example, orthopedic procedure, which is a very painful one, then you may need to, the best really is to give an epidural or regional anesthetic for this one. If for some other reasons, you can give a PCA opioid, but the message here is as much as possible, you try to avoid opioids, or as much as possible, try to lessen your opioids in ICU patients, because opioids in itself can cause delirium. And actually, prior to giving your PCA opioids, try considering first your non-opioids and some other non-pharmacologic measures.
Yeah. I am very curious with your recommendation for non-pharmacologic measures, because if we take a look at it, there are recommendations for music, there are recommendations for reassurance, and most often than not, the recommendation for us to have our patients sedated would be because of their agitation, restlessness, that you cannot even think of initially starting them with, sige, i-music na lang muna natin ito, di ba? So, how realistic is that, Dr. Belay?
Well, it's the nice thing about these non-pharmacologic measures or techniques is that they are, they're low cost, and it has been proven that they are very effective. Like the simple dimming of the lights at night will definitely help in promoting sleep in your patients. Keeping your ICU quiet at night will again definitely help in promoting sleep in ICU patients. So unfortunately, these things are overlooked, but these are very important, and in fact they should be the first intervention or first measure to take before going into the pharmacologic interventions.
Yes, that is so ideal, no? Kaya lang good luck with that. When we're in the ICU setting, yung mga alarms are just starting to create that atmosphere of anxiety talaga.
Exactly.
Okay. No? Oo. Here, another question for you, Dr. Belay. Should benzodiazepines be routinely administered with ketamine to avoid hallucinations? Kasi you have recommended that to
Yes.
attenuate the effect of ketamine with the hallucination, you can give your doses of benzodiazepines.
Not always or not necessarily, because when you're giving low doses of your ketamine, yes, there is a possibility of psychomimetic side effects, but really it's not really life threatening or not a big or major problem, and it's very simple to treat or to address. Simply bring down the infusion rate, and the psychomimetic side effects will be resolved. In fact, most patients, when they tell you about this hallucinations or psychomimetic side effects, they actually think they're funny. Some patients would think, uh, Doc, akala ko may langaw, wala naman pala. Things like that, or they would text and then they would realize that they're not holding their cell phones, and then they would laugh about it. So it's really not a big problem. All you need to do is just decrease the infusion rate. So again, not always. You don't need to give benzodiazepines whenever you're going to start your patients on sub-anesthetic doses of your ketamine.
So it's also very important that you establish a baseline for
Yes.
the like what you said, you would have to have the guidance of a CAM ICU
Yeah.
and all these things, so that you'd
Yes.
be able to differentiate and have an accurate monitoring of how your patient is, no?
Yes,
While
that's
you are
correct.
giving medications.
That's correct.
Okay, we go back to you, Dr. Pablo. How would you know if it is catheter-associated infection, and what pathogen is most likely to grow in cultures in these cases?
Yeah. There's actually a definition that from the Center for Disease Control. It has to be catheter-related infection has to be the catheter has to be in place for more than 48 hours. There is no identifiable other identifiable source, and it is there is already a culture. These this is given because so we can avoid unnecessary removal of catheters. Sometimes if there's infection, because if we treat all infection as catheter-related infections, we will remove all the catheters. And sometimes these catheters are central line catheters are what they call this are vital in managing critical patients. So if there is no need to remove this, we don't have to. But most probably our staff, their enterococcus, and the critical thing here is once you remove the catheter, you have to culture the tip. So your management will be catheter pathogen directed antimicrobial therapy.
Okay. That you encountered most of the infections are around the area of the femoral region, no? Is it because
yes.
in the vicinity or the area of the perineum that makes it more susceptible?
More susceptible to infections. There's pubic hair there, the underwear usually covered, the diaper is there for critically ill patients. And these are actually, there is evidence here, there has been studies that have shown, that have proven that infection rates are really, really higher for femoral. So if we can avoid, this is the last, I call this the last option among the three sites that we discussed earlier. And also with the risk of DVT, we would want to avoid, especially in patients who are critically ill, they're not moving, they're in bed for most of the time. So we would want to lessen the risk for DVT.
Okay pa nga if we encounter yung mga infections of the staphylococcus kind, but there would, for critically ill patients, we see mga rare pathogens growing, mga pseudomonas and mga and all those. Okay. Another question, Doc. A 10-year-old boy who was diagnosed with CKD and at the same time has a cervical neck injury, he will be allowed to have femoral catheter regardless of age?
Usually 10-year-olds are usually very small, so the catheters that we use are about 13 French. Sometimes it will be too large. For these patients, I think the ideal approach if patients would need dialysis is more of a peritoneal dialysis. Since I think most of the pediatric patients, only a few of them actually undergo HD. And if we ask the pediatric nephrologist, I think the recommendation here will be a peritoneal dialysis if there are no contraindications.
Okay.
But if it's an emergency, there's nothing we can do. Ultrasound guidance will actually show us if the caliber of the femoral vein is large enough for catheterization. But again, if there are other sites, better ways to do it, I just avoid it.
Okay. Sige, doctor. Another question for you, Doc, ha? Can external jugular vein be used for CVC? What risks are involved?
Yeah, actually, we do use the external jugular vein. We use the smaller diameter catheters, the French 5. The risk here, I think, are minimal because it is located just superficially. It's just below the platysma. It is easier to compress when it is when you advertently rupture it or there's hematoma. The problem is it takes skill actually to insert. It's not very easy to cannulate the external jugular vein. You can do it if for patients who have heart failure, have very distended neck veins. It is much easier, but again, it's a skill that you have to acquire.
Okay. Doc, meron pa bang value of using the Allen's test for your arterial line insertion, or because of the advent of the ultrasound?
Yeah, ideally, still ideal. I'm sorry I didn't mention it, but it's ideal that you always do an Allen test before you any procedure on the artery. What we do use now is you use the modified Allen's test. It's good if you look for the peak systolic velocity of the radial artery, and then you compress the ulnar artery. If there is an increase of more than 50%, then you know that your palmar arch is patent. So But for those who are not familiar with the ultrasound guidance, the clinical Allen's test can be done. You put what do you call it, a pulse oximeter on the finger, then compress the ulnar and the radial arteries, and then that's how you test it. You see, they release one after the other. So you can also see the waveform if the flow goes back faster.
So it's always safe also
Yeah,
to be.
it's always recommended to do an Allen's test.
Okay. Thank you, Doc.
Thank you.
Back to you, Noel.
Yes.
Is dexmedetomidine approved for use in pediatrics, and at what dose?
Honestly, I have no experience using dexmedetomidine in pediatric patients. So maybe some pediatric intensivists would have more experience on that, but I have no experience with pediatric patients.
Okay, I know of one who has tried using, and then they reported bradycardia, and then they immediately terminated it. I think it's not yet recommended. I think it's still it's still an off-label use when
yeah, exactly. They might be using it as an off-label, but
okay. Sige, Noel. We'll proceed with the next one, ha? Can we use dexmedetomidine when intubating a patient instead of propofol in an awake patient? Teka, did I get this right? Can we use dexmedetomidine when intubating patient instead of propofol?
are we talking about the awake intubation?
In awake patient. Oh, is it available in the Philippines? Maybe the one who sent this is not from the Philippines.
Okay, if you're using dexmedetomidine for awake fiber optic intubation,
yes,
then you can definitely you can use dexmedetomidine. But if you're using dexmedetomidine for let's say if you're trying to intubate a patient in the ER or in the operating room, then you cannot use that, because like I said in my lecture, it's suitable for light sedation but not suitable for deep sedation, and you
correct.
definitely need to knock down your patient when you intubate them, unless of course you have issues or concerns with the airway.
Yeah, especially now in the COVID era, you would want a patient who's not at all coughing and gagging.
Yes, exactly.
Okay. Okay ka pa ba, doctor? Doctors, you're still okay, ha? We still have, they
Yes,
keep on coming. The questions are still,
Apo.
sige, go ahead tayo. Which is safer or ideal? Alprazolam or melatonin if a patient is complaining of insomnia for almost a week?
For almost a week. Okay, number one, is this patient an ICU patient, or like I said, you need to start with non-pharmacologic measures first. Like we have to ask, well, what's the cause, or what's stressing the patient basically. So if the patient would say the ICU is too noisy, or it's the lights are too bright, then you may need to address those issues. Now, if the problem is insomnia per se, I would recommend melatonin because of its physiologic mechanism of action as compared to your alprazolam, which is basically a benzodiazepine. So I would start this patient at night. I would start with around 3 milligrams of melatonin and see how the patient would respond. Regarding melatonin, it's a very safe drug. In fact, millions are using it, and studies have shown that the safety of melatonin, even up when it's taken up, even if the dose is around 1,000 milligrams. But of course, I will not start this patient on 1,000 milligrams. So ideally, you start these patients on 3 milligrams at night or maybe start 3 milligrams around 8 p.m. and then give another 3 milligrams around midnight.
Okay. Oh, thank you for that. Oo. So, there is also such a thing as tachyphylaxis ba for using melatonin, that you would have to be increasing your dose as you as the
Well,
patient.
not really. You just need to find the so just like the opioids, you need to find it. It's like looking for the
Happy medium.
yeah, exactly. So,
Okay.
but a
Oo. The
reasonable
sweet spot.
dose, yeah, a reasonable to start is around 3 milligrams at night. A
Oh.
reasonable dose.
Kasi so it all boils down to the origin of the distress actually, no?
Exactly.
Mm-mm.
So, like I mentioned earlier, there are several stressors in the ICU. Bright light, noise, of course,
Pain.
anxiety.
Mm-mm. Okay. We have the last two questions because we're running out of time also, and we also do not want to keep you from doing your other things, Dr. Bele and Dr. Pablo. So last two. What would be your recommended dosage, frequency, and duration for melatonin in an individual experiencing difficulty sleeping due to depression and anxiety?
Okay, so like I said, if you plan to start melatonin, a reasonable dose is around 3 milligrams at night, and maybe you can double that. Take another one around midnight. But really, the answer to that is you have to um, investigate or look for the cause of the stress. So if we're talking about ICU patients, there are a lot like, again, pain, isolation, things like that. So before starting any pharmacologic interventions, let's focus first on the non-pharmacologic interventions first. And you'll be surprised that there are several causes of anxiety and depression or stress in ICU patients. The mere fact that they're isolated, that's already a major stress for these patients or a major cause for anxiety.
Okay. So there are still some questions in the chat box which I think I will not be able to answer anymore live. So doctors, if you are free and you still have time, maybe you can just check on this and if you can personally answer these questions, no? But just to ask the last question, this is to Dr. Belay na lang. The daily interruption of your sedation would not be so beneficial if ano lang siya. What was that you mentioned about the daily interruption?
Yeah, if your daily sedation interruption or DSI as we call it offers no additional benefits when your protocol is already targeting a light sedation level. So if your ICU protocol, let's say your default is -2 to 0, so that's light sedation, then doing daily sedative interruption will not give any additional benefit.
Benefit.
Yeah, because the drawback or the interesting finding in that study is with the daily sedation interruption, they end up consuming more sedatives in these patients because after waking up these patients, they need to give more sedatives to put them back to sleep.
It's like restarting all over.
Exactly.
Because also the purpose of doing so is that you do your neurocognitive evaluation again, you do your monitoring. Yeah. Is that correct?
Yes.
Oh.
So as long as your protocols in the ICU is targeting light sedation level, then you don't need to do daily sedation interruption.
Okay. All right. Again, depending on the root cause, then you use your appropriate tool in order that you maintain that light level of sedation. No?
Yes.
Okay. All right. I think that's about it. And we've had a very interesting discussion. Thank you for the wonderful exchanges that we have just had. Dr. Pablo, thank you so much.
Thank you.
And thank you to you as
Doctora.
well, Dr. Noel Bele.
Thank you. Thank
And
you.
this would wrap up our